Jane Addams, the founder of social work, once said, "The good we secure for ourselves is precarious and uncertain until it is secured for all of us and incorporated into our common life." This powerful statement embodies the spirit of our Jane Addams Consulting Group. My name is Chriselle Marie Arbon, and I am our community liaison. These are my colleagues.
I'm Jennifer Neely. I'm the operations coordinator.
I'm Martin Finnegan. I'm the strategic planning coordinator.
Hello, I'm Lali Akarati, and I'm the financial advisor.
We are excited to work with you all to accomplish our common goal of bringing home to Hennepin County. Although we were tasked with providing a solution for the growing encampment, we understand that the encampment has recently been closed. Therefore, our solutions will be based on the current state of homelessness in Hennepin County. Let's start with our agenda. First, we will share key information about the homeless encampment in Hennepin County and the stories of 3 of its residents. Then we will go over the current state of the encampment and the key issues that we identified through our root cause and gap analyses. We will then propose our strategic initiatives and walk you through the implementation timeline. Finally, we will discuss the financial projections of this program, its sustainability, and end with our outcomes and conclusion. In the past 4 years, the amount of individuals experiencing homelessness outside of a formal shelter has increased 93% in the Twin Cities metro area. By December 2018, nearly 300 individuals were staying in a homeless encampment in South Minneapolis. Native Americans and African Americans or Blacks are overrepresented. Furthermore, about 83% of adults experiencing homelessness in Minnesota have either significant mental or physical illness, and these conditions are represented through our client stories. First, we have AB. When he became homeless, he failed to practice proper oral hygiene, leading to the loss of 4 teeth. He tried to access dental services, but they were always booked months in advance. And when he tried to get back on his feet and find a job, he had trouble because of his missing teeth. Client CD has a bipolar disorder, substance use disorder, and asthma. One day, he had a severe asthma attack without his inhaler that sent him to the emergency room. And finally, we have EF, who is a single mother with a learning disability. Her part-time job doesn't pay her enough to afford her own place, and the temporary housing system doesn't consider her and her daughter vulnerable enough to be granted affordable housing within 9 months. These are just a few stories of those experiencing homelessness. We understand that many efforts have been made in the past to end homelessness in Hennepin County. We studied how your organization implemented your 10-year plan in 2006, which prioritized prevention, housing opportunities, service delivery and systems improvement, and self-support. In 2016, you reevaluated your plan and updates were made for the following years. We believe that our recommendations could further help you move forward from the current state to achieve your goal of functional zero. But what exactly is this current state? In December 2018, many from the encampment were housed through Native-led operations or relocated to the newly opened Navigation Center, which facilitated the closing of the Hiawatha and Franklin Avenue encampment. The center is a safe, clean, and secure compound that offers low-barrier shelter with no sobriety restrictions, unlike a majority of the existing housing services. The Navigation Center provides intensive support services, such as Suboxone induction and culturally informed services, including Native healing practices. However, this is not a permanent solution. The Navigation Center is scheduled to close by June 1st, so additional support is still needed to address the key issues. Through our root cause and gap analyses, we identified 3 key issues that build on one another. Housing insecurity is the first challenge. Based on a single night count of people experiencing homelessness done by the Wilder Foundation in 2018, the percentage of adults aged 25 to 54 in Minnesota who were not staying in a formal shelter increased by 96% since 2015. Housing First is a model that prioritizes housing rather than implementing strict rules that could actually become barriers to housing. Evidence supports that Housing First models are effective ways to address homelessness and health, leading to chronic health conditions as the second key issue. Though Hennepin County is a service-rich environment, it lacks coordination between services. At the heart of it, the existing system is complex. Imagine how much harder it would be to navigate these services with housing insecurities and chronic health conditions. Therefore, the gaps must be closed amongst the existing fragmented services. However, one common setback that remains when attempting to address these issues is the reality of funding constraints. I will now hand it off to our operations coordinator, Jennifer.
Thank you. As Chriselle mentioned, we're named for Jane Addams, the founder of social work. And it is in this spirit that we would like to share with you our philosophy and the values central to this proposal. First, our philosophy is that housing is fundamental, that healthcare is a human right, that we can achieve better health outcomes through housing, and that to accomplish this, collaboration and communication are essential. Our philosophy is driven by our values, where we place a priority on establishing trust, providing compassionate, patient-centered care, respecting the agency of the individual, and practicing cultural humility. This philosophy aligns neatly with that of Heading Home Hennepin's. In the 10-year plan, you stated that people deserve safe, decent, and affordable housing, that providing services without housing does not end homelessness, that homelessness costs more than housing, and that housing the homeless is attainable. We agree, and this is what gives us hope. HOPE is the name of our strategy. It stands for Health and Housing Options to Promote Empowerment. HOPE aims to address Hennepin County's twofold problem of healthcare and housing individuals who experience homelessness by implementing 3 initiatives. The first, the street team, will provide on-site medical care in a manner that focuses on earning the client's trust, at which point they will also attempt to recruit them into permanent housing. Second, the home team will be a team of case managers to help our clients navigate services as well as provide them with integrated primary care. Finally, the behind-the-scenes partnerships between HOPE and various community and civic service providers will contribute to the ultimate goal of getting and keeping people in housing for their better health. To go into a little bit greater detail, the street team will consist of a volunteer doctor or resident, a volunteer nurse or DNP student, a licensed social worker, a peer support counselor, both of whom are paid positions, and student service learning volunteers. Their mission is to meet individuals experiencing homelessness where they are, to establish trust and provide care on their terms. They will provide both urgent care, such as treating exposure-related conditions and administering naloxone, as well as primary care, such as treating wounds, Suboxone induction, and managing chronic conditions like diabetes, hypertension, and asthma. Beyond that, the social worker will complete comprehensive assessments with each client to identify and prioritize their needs. The key member of the street team is the peer support counselor. This is an individual who themselves is formerly homeless, and they will help the team establish a rapport with each client and guide the team in the etiquette that will help us provide culturally competent care. To illustrate how this would work, let's look at CD. He's resistant to healthcare due to his distrust of the healthcare system. By meeting him on his terms, the street team could provide him primary care, including getting him treatment for his asthma, bipolar disorder, and if he chooses, his substance use disorder. A closer look at the home team will show us that it consists of 3 paid positions, a licensed clinical social worker, a part-time advanced practice nurse, and an administrator, plus volunteers. These folks will work to identify and coordinate all available resources to assist clients into permanent housing. And they will also continue the primary and mental health care that the street team began. The home team will work closely with the administrators of the Navigation Center, as well as other partners to relieve their caseloads. They'll assist in placement and retention, and to illustrate why this coordinating function is so critical, we should consider one of our cases, AB. AB missed his dental appointment the home team could have helped him by reminding him of it. They could be a point of contact for his clinicians. They could have gotten him discount transportation passes. So that's all functions that the home team could provide for him. To illustrate the sort of resourcing functions that the co-located home team could provide for someone like EF and her daughter, they would be able to help her secure housing not on the wait list. They would help her get financial management, and they would help her get mental health care. So this is a little bit of what hope looks like to us. And now I'm going to pass it to Martin, who's going to tell you what hope is.
Now that Jen has told you about the structure of our HOPE teams, I am going to walk you through the operations process. As you can see, the street team will provide outreach, on-site care, and complete a comprehensive assessment to determine the individual's needs and risk level. The home team will coordinate supportive services, continue primary care provision with behavioral health services integrated, and provide ongoing case management once individuals are housed. The heart of this strategy is collaboration. The street and home teams will meet in daily huddles to discuss individualized care plans for the clients that have elected to accept HOPE services and coordinate their path through the continuum of care that they need to get healthy. The home team will also collaborate with the street team to transition clients into permanent housing. Once clients, such as the 3 individuals in our case, have stability and become healthy, we will let them decide if they are ready to transition out of our care and provide them the support and advocacy needed to sustain themselves. The HOPE service providers will respect your client's agency and right to self-determination and empower them to provide for themselves and their families. The HOPE strategy is unique in that it aims to fill the gap between existing services through various partnerships. We have identified key partners whose guiding principles and values align with the HOPE strategy and Heading Home Hennepin. The teams will work with a coalition of civic partners that have the backing of those connected to government programs and resources, such as job placement programs. Housing partners will be able to provide emergency housing and shelters and help transition clients into permanent supportive housing. Medical staff volunteers will be recruited through provider partnerships to ensure best practices for HOPE services and will also be consulted for any service delivery issues. Community partners will provide logistical support and expertise on cultural considerations for your clients, many of whom are Native Americans. Health professional student volunteers will be recruited from universities' service learning programs. Finally, hospital partners will be key financial stakeholders. The costs of a fragmented system are borne primarily by hospital emergency departments. In this case, we identified hospitals in close proximity to the former encampment to contract with. In other metropolitan areas, street medicine programs are acting as care providers for the homeless patient population and are using hospital contracts as a funding mechanism to sustain their programs. Typically, these contracts are for $10,000 per month per contract. The HOPE initiative plans to replicate their model by creating a contract between Heading Home Hennepin and 3 nonprofit hospitals to provide primary and urgent care for individuals experiencing homelessness in their service area. This, in turn, will decrease emergency department and inpatient utilization at the 3 partner hospitals, alleviate HOPE program funding constraints, and promote collaboration between these healthcare providers. In year 1 of operations, we will demonstrate the value of our services and then contract with hospital partners starting in year 2. This table shows the monthly contract amounts per hospital over the span of 4 years. As you can see, the monthly contract amount per hospital starts at $10,000 and increases slightly each year to financially sustain the street and home team expansion into 3 teams by year 2024. Here is our implementation timeline. In year 1, the initiative will launch operations with 1 street team and 1 home team, both of which will be mobile. These teams will aim to enroll 10 clients into primary care and serve 60 individuals with on-site care. In year 2, home base will be established by leasing an office space for the home team, which will hire a full-time administrator and part-time advanced practice nurse to complete home visits with a licensed clinical social worker. Operations will expand to 2 street and home teams, which will aim to double the client base to 20 clients enrolled in primary care, serve 120 individuals with urgent care, and also aim to transition 20 clients into supportive or permanent housing. In years 3 and 4, HOPE programs and services will be sustained and aim to transition another 20 clients into permanent housing. In year 5, operations will be expanded to 3 street and home teams and aim for a total of 30 clients enrolled in primary care and serve up to 180 individuals with urgent care on the streets. Finally, we aim to transition 20 additional clients into permanent housing. My colleague Lali will now tell you about our performance metrics.
Thank you, Marty. Improvement cannot be achieved without measurement. Our strategy is embedded within a PDSA approach for continuous improvement for the HOPE teams, our stakeholder partners, as well as, most importantly, the health and housing outcomes for the clients that we serve. This slide shows our proposed performance metrics for the street and home teams. As you can see, there are 3 major domains under street team, including primary care enrollment, on-site care provision, and comprehensive assessments with their associated metrics. There are 2 major domains for the home team, including case management and integrated primary care and their related performance metrics. My colleagues have shared with you various elements of the HOPE initiative, but none of this matters if we cannot financially sustain this model over time. Let me share with you the budget to sustain this initiative. This first table at the top shows the revenues we expect over the projected 5 years. As you can see, we have accounted for the one-time grant of $250,000 in year 2020. We have also accounted for the associated hospital contract amounts for the remaining years. The second table at the bottom shows the HOPE strategy budget expenses over the projected 5 years. We have accounted for the salaries of our paid staff, the expenses for the supplies for the street and home team, as well as the office space for the home base. We have also accounted for line items such as the electronic medical record and liability insurance costs. The expenses increase over time in commensurate with our service expansion. To show you how financial sustainability maps out over 5 years, here is our projected income statement. As you can see, there is a net income of about $60,000 in year 2020, which is cycled back to fund operating activities for the subsequent years. The cyclical model is incorporated throughout the projected 5 years. And to further ensure that functional zero is not only feasible but functional, the return on investment is calculated to be 20% and the net present value is $268,000. In closing, we have shared with you Jane Addams Consulting's HOPE strategy. The HOPE strategy aims to address healthcare and housing through the street team, the home team, and partnerships and contracts within the community. This initiative was formulated to bridge the gaps within the existing fragmented system to ultimately improve the quality of life for the individuals experiencing homelessness within a financially sustainable model. We are confident that this proposal will support Heading Home Hennepin to achieve functional zero. We at Jane Addams believe that the population we aim to serve is resilient, and we want to emphasize their strengths rather than focus on the negative aspects of their experience. To conclude, I will leave you with the words of Father Gregory Boyle. Here is what we seek, a compassion that can stand in awe at what the poor have to carry rather than stand in judgment at how they carry it. We thank you for your time, and we are happy to answer any questions you have.
Your focus on the Navigation Center and the primary emphasis on the Native American community that's been the primary recipients of that particular service. How does that juxtapose with the primary emphasis on a medical model response, given the cultural implications of that community, specifically within Minnesota, and the complexity of the number of different tribal communities we have that are scattered across the state that get aggregated here in the Twin Cities.
Definitely. We have a slide that we can kind of go back to answer that question. So one of the guiding philosophies and values that we have is to establish trust. And so the medical team, they will be spending a lot of time building that trust with the individuals, especially the Native Americans that they're going to be coming into contact with. And so we understand that other street teams across the nation who are implementing similar programs, oftentimes it takes about 6 months just to build that rapport. Additionally, we have a peer support counselor who is also included as a key member, as my colleague Jen mentioned, of the street team. And they actually, being formerly homeless as well, that we are employing, will kind of help us make that first step to actually make that connection and help us build rapport and provide that culturally competent care. If you have any further questions, I can definitely add on to that.
Well, it appears that your model focuses first on the primary care emphasis and you know, from that medical framework. And clientele generally doesn't think about the healthcare system as the first go-to place. So you've got a big gap between the cultures of those two systems and groups. And so it seems like you had your connector through your case managers and your social workers secondary, which seems contrary to how your model may or may not work. Because you haven't connected effectively with the clientele, but you're expecting that clientele to engage actively with your healthcare system.
Yes.
That's what I'm trying to ask. How do you get that effectiveness done?
I think that's where the cultural humility probably comes in.
Yeah.
And using that peer, so cultural humility is the provider understanding that they do not necessarily know how to treat the patient because the patient might have different needs culturally than what the provider is used to treating. So we are actually going to use the peer support counselor to act as the go-between to start to gain the trust from the community, talk to them about what they need, how they would like to be treated, and then if there's something that the primary care provider can do that works for that patient or that client, they will then go forward and do that.
So does that cultural humility then mean your model is still upside down because you're leading with a westernized medical model versus orientation to the indigenous?
That's a good question.
I think it's important to know that historically this population has been known to not trust the shelter system due to the trauma that has been inflicted over generations. So I think getting them enrolled in primary care they will accept our services once we build that trust. And then once we have them enrolled in primary care, the case management team can kind of take over that navigator role. And so then from there, we get the point of contact, we get them enrolled in services, and then we can really address kind of all the supportive service needs that they might have. Ideally, the peer support counselor will also be a member of the Native American population, and so I think that will help build the trust in that our providers are going to provide competent care and take these considerations seriously.
To also add, I'd like to stress that the street and home team are dual initiatives. So they are being implemented simultaneously. And so the street team and the home team have daily huddles, which is the center of the slide where there's a collaboration. So that linkage between care and then that link for case management and housing retention, we hope that this will kind of cater the solution and be able to help work the people that we're trying to serve, such as the Native American population.
Thank you.
So I am a little unclear. I didn't catch it if you explained how I have a pretty clear vision based on the way you explained it about how the street team works and engages and what that looks like. You lost me a little bit in the transition to the home team. Mm-hmm. So the home team, I presume, infers that people are in housing. Is that fair?
Yes.
Okay. So how does that housing connection happen? What is the housing? How does that piece work?
Definitely. So Hennepin County has actually invested quite a few $1 million into housing initiatives already. And so Also, the Red Lake Nation organization, that's also where the Navigation Center is located. It's located on their land. They are spearheading housing initiatives. They are recently also planning to build a permanent housing unit that's supposed to be 110 units. And so housing is already the primary focus of the community and in the present day. And so what we are trying to do with the home team and the street team is provide support. So they are going to focus on case management and housing retention, because it's naive to assume that once an individual gets housed, nothing can happen that will prevent them from falling through the cracks. And so the primary focus is to ensure that we are bridging the gaps within the existing system.
I think an important distinction is that primary care responsibilities will be transferred from the street team to the home team once these individuals are housed. And the home team is unique in that it can provide behavioral health care with a licensed clinical social worker, which can be psychotherapy, substance use disorder treatment, and the advanced practice nurse can continue to monitor chronic conditions as needed. So I think meeting them in their home will kind of keep that rapport ongoing, and that trust that's already built can kind of sustain that.
Thank you very much for your presentation. You talked about performance metrics, which is really good. You're going to look at sort of the outcomes of the work that you're doing. I'm wondering about any other types of ongoing evaluation that you would do to ensure that the services you're delivering, starting with the street outreach, with the street team and moving forward, is actually achieving the goals that you set out to achieve.
Thank you for that question. So in terms of some things that we can measure, the CDC has proposed something called the health-related quality of life measures, which is something where you can use to evaluate how the patients are actually doing and actually numerically calculate whether they are reaching an improved quality of life. So that is one option for what we can do in the community.
And I would also add to that, that as with any model, we would be using PDSA cycles to improve and try to get better.
Using what?
PDSA cycles.
Plan, do, study, act.
Yeah.
It's an iterative model where we will improve our service delivery.
Is that effectively rapid cycle change? Is that the same?
Mm-hmm. Yes.
Thank you.
I am excited about the peer support coach position. Can you say anything more? I mean, so you've mentioned that it's someone who's experienced homelessness, probably a focus on Native American recruits for the job. Can you say anything more about training, about what that a qualified person looks like for that role? Anything?
We're also very excited about that. One of the things that makes us most excited about it is by providing employment, not just providing a service. I think that we had talked a little bit about the kinds of training that person would have. I believe that if we do a sort of a values-based interview and just pick the right person, we might not need to get them schooled per se. If they want to, we can support that in the future. But as far as the rigors of their job, as long as they're good and compassionate and can connect with people and can help us, know how to connect with people and know how to connect with that population, that's a good start. Again, if they want to go further with their education and get more schooling, I think we could try to support that later, especially with some of our university partnerships.
Off of what Jen mentioned, there are specific training programs where they can become better equipped to handle that kind of role.
Okay.
Oh.
Sorry. Thank you.
No,
Yes.
thank you.
Thank you so much for your time.
Yeah,
We
thank you very
appreciate
much.
it.